Good evening, everyone. For the last session and debate for 10 minutes. It's on metronomic as a maintenance solid tumor. And for me, the answer is yes. So I won it. So this is a cartoon, if anyone has seen, has won the first prize for the Economic Times for Panama paper leak. And I took it up that we have still understood this much of chemotherapy, and most of the chemotherapy effects and the microenvironment still underlie. And with each year, with each decade, the concept of chemotherapy is changing. And that is what it is all about. And for my dear friend who's going to speak against me, I pity him. He's looking at this part, but I look at this part of the story. India, 1947, August 15th, independent India. This is cricket. Most of you would not, but few of the Indians will love it. This is a ball here on the offside, and we used to sweep it normally. Now we reverse sweep it. So, and then came the helicopter shot of a favorite Indian cricketer, Dhoni. So what I mean to say is, to my opponent Senthii, who's a dear friend, the only thing constant in the life is change. And you cannot stick to what you have been taught for 20 years, that chemotherapy and maximum tolerated dose is the way to go ahead, and metronomic, I think, should be the way to go ahead. And it has its own advantages, which you all know. It has a lower toxicity, lower drug resistance, it has anti-angiogenic effect, and it boosts the immune system. Why maintenance? Because the topic was maintenance of metronomics in solid tumors. I just quote one study. If I do not go for maintenance, you would be losing out of 40% of patients whom you would never give any therapy. So definitely maintenance is, I think, would be the way to go ahead in most of the agents. And this is the lung trial, the Paramount study. And for the patient perspective, before I go into what I will be touching, this was a beautiful thing, patient maintenance therapy for advanced non-small cell lung cancer, a patient perspective. And when they were asked, if you were to take maintenance, what would be your endpoint? Definitely cure is my endpoint. But apart from cure, something else, and majority of them told that tumor control would be sufficient for me if I'm going to have a good quality of life. Should it be IV or should it be oral? Majority, as usual, told that oral would be the ideal way of giving maintenance. And the last question asked to them was, most of them told that they would take a maintenance only if the toxicities were better or at least mild. If it was very severe, only 5% agreed for maintenance. So all this, why I showed you, was to tell that if a maintenance, which is a trend today, it has to be something with less toxicity, and if that is it, it has to be metronomic therapy. This is the article of JCO, and this was published in 2013 for a maintenance lung trial, and the last line catches me. For maintenance therapy to be broadly acceptable patients, clinicians and payers, it needs to be convenient, well tolerated, cost effective, and should prolong OS. So I base my debate on these 4 points: convenience, well toleration, cost effective, benefit. Is there a rationale to this? And we have been hearing and listening to this, and the paper has been alluded to. Metronomic chemotherapy following the maximum tolerated dose, the switch effect, and we know that the chemo switch schedule does play a role, and we know that after a maximum tolerated dose, if you give maintenance and a metronomic dose, it does help the tumor not to spread, and it also helps in anti-angiogenic effect, and that is also helps in tumor not to disseminate. And this schedule definitely shows that apart from anti-angiogenic effect, if you have a switch model, it definitely has much more benefit and more cell control than any other effect. Now coming to efficacy data, definitely there's a lack of data, but the data is still staring at us. We need to just produce the data. The metronomic methotrexate and endoxan after carboplatin included adjuvant chemotherapy in triple negative breast cancer, phase 3 study. So this is a phase 3 study. They were from Egypt in 2014 ASCO, and they had TNBC patients who were after adjuvant chemotherapy assigned to metronomic versus nothing. And these patients were 158 patients, and concluded that extended adjuvant metronomic chemotherapy achieved significant improvement in OS, DFS, and further they were well tolerated. Second, from Tata colleagues from here, Metronomic maintenance therapy and prevention of relapses in patients with triple negative breast cancer, a retrospective analysis from Dr. Banawali group. And they did again after the standard 6 cycles of chemotherapy, TNBC patients, triple negative, they had a maintenance therapy which was little exhaustive, little lengthy, and they had first celecoxib, endoxan along with weekly cisplatin for 12 doses, and then followed up with oral metformin, endoxan along with weekly methotrexate. And they found that there was a OS survival benefit in the maintenance group compared to the observation group, which is statistically significant. To the head and neck study, which was presented in the afternoon, and the Tata group again found that the celecoxib and weekly methotrexate was far more superior to the cisplatin normally which we have been giving. Of the 110 patients recruited, they found that the OS was beneficial, the patient had a prolonged PFS, and the toxicity profile was also much better. Coming to a much larger, well-published maintenance study on metronomic, the Cairo 3 on colon cancer. And this was on a capox-B, fully formulated dose versus observation versus cap at a lower dose with BEV. And on progression, they introduced capox once again. And they found the PFS, the maintenance was much better. And the second progression on the addition of capox-B, it was much better. And even the maintenance arm produced a survival benefit compared to the observation arm. And the global quality of life did not deteriorate during maintenance treatment and was clinically not different between the observation versus the patients who received the maintenance. So these were the major efficacy data apart from the brain trials, which has produced that the maintenance way of giving metronomic is a better way to have a disease control and better quality of life. Cost effective. I come to the second parameter. The maintenance chemotherapy for the advanced non-small cell new life of old, I went to the last paragraph of it. The economic consideration in maintenance chemotherapy. I calculated this, which is a pemetrexed maintenance, and I calculated it to the Indian rupees. It was 22 lakh rupees of Indian rupees for a cost effectiveness per life year gained. And I come down to the Avastin, which is used as a maintenance. And this comes up to 2 crores odd Indian rupees for maintenance for a quality of life adjusted per year survival benefit. I compare this with a normal metronomic for endoxan and as a cisplatin or probably low dose or probably methotrexate, which will not cost me more than 100 to 200 rupees, and the cost definitely is much more effective. Now coming to the metronomic as maintenance, this was a study again, we have the authors here, and it was in collaboration with the colleagues at All India Institute. And I've come up to this, that India, I still believe, is a country where 20 to 30% would afford anything which the world can afford. But 70% are those who are really struggling, but 10 to 20% are those who really do not know where their next meals are coming from. For such a country which is as diverse as India, as vast as India, I feel we still fall into the low middle income where majority are not able to access to a good quality targeted therapy doses. So, as we have proposed earlier, metronomics may be a promising alternative strategy for the improvement of cancer care in low middle income countries, and we although aspire to, but the truth is, for my country, only 20 to 30% can afford anything, but rest 70, we have to find solutions for them. And for those, I find, if I go on and tick this convenience, I feel the maximum tolerated dose, no. And for maintenance, I feel it's much more. As the discussion went on, Dr. Banawali told one pill, go back, and we know that probably the compliance will be much better. Well tolerated, yes, toxicity is definitely superior to a maximum tolerated dose chemotherapy, and it is well tolerated. Cost effective, surely cost effective. I showed 2 crores and at 200 rupees, it's like $1 versus $5,000 or $10,000. Survival benefit, I do not have. I argue still on this stage scientifically against the survival benefit for a maximum tolerated dose chemotherapy for maintenance. I can do the same for the metronomic therapy. So, I know my friend is laughing, and all of us know this man. He was on Times cover. He's got to India. If you know cricket, you know him. He's Sachin Tendulkar. And This is what the fan following is for him. Some things never change. Cricket still a religion. Tendulkar still as God. And this was the man, at the 15 years boy, pushed into international cricket. And he never played a domestic cricket and went straight into represent the India. He never played Ranji for Mumbai. I put it up to tell you that you need to look beyond. You just cannot follow a phase 1, phase 2, phase 3 and then go into clinics. Sometimes things are looking at you, you need to push them into clinics. And for my friend, he is as a glaucoma patient would look like, a narrow vision. And I know that the picture is this. And he only looks at this way. And with this little bit of insight, I conclude and give him little advice to have his eye checked so that he can see the things better and think that metronomic is the way to go ahead. So, there is a rationale for this approach. More mature and robust data definitely needed, but whatever data available looks pretty encouraging and is worth trying, especially for a country like mine. Thank you.
So now let us hear from Dr. Senthii Rajappa as to how he looks at the metronomic chemotherapy as a maintenance for solid tumor.
So I was wondering whether Sahoo was taking a history class or whether he was talking about metronomic chemotherapy. Right. So my do for the day is to say that there's absolutely no role for metronomic chemotherapy as maintenance. Sahoo started by... The other thing that I want to say is that he spoke so much about cricket, which means the match has already been fixed. Okay? Doesn't matter. So, it doesn't matter. If you feel like you want to be underwater, so be it. Remain there. And I think you will remain there forever because there will never be maintenance. Okay? So that's what I will try and show you. So I have to confess that I don't know anything about this field, and hence, what do all of us do? We go and search in PubMed. So I typed metronomic therapy, and you got 756 articles that came up. And then when I said metronomic maintenance, it became 49. It didn't take too long to go and search all the 49. In fact, don't think that I didn't read the first one. The first one consisted of 4 patients. Okay? So whether you read about 4 patients or you don't read about 4 patients who had maintenance, it doesn't really matter. So I said, let's learn better because you have to do the debate. I went to Professor Google and typed this. So it came back with 42,400 in 0.59 seconds. What did I do then? I typed TP Sahoo. Sahoo returned 1,52,000 in 0.41 seconds. Right. So people know much better about Sahoo with an inverted commas than about metronomic maintenance. And look at that naughty smile there. Once upon a time, Sahoo was young, naughty and smiling, and now from his maintenance debate, you will definitely know that he's grown older because he tries to convince everybody about something that doesn't exist. That's what old people try to do. And that's what Sahoo is doing. Okay, let's get serious. So this is Hanahan's definition of metronomic, and that is the NCI's glossary's definition of what maintenance therapy is. So gladly Sahoo didn't talk about olaparib and so on and so forth, so I don't have to reinforce point number 1. Point number 2 clearly says that when you're using maintenance treatment, it has to prevent tumor progression after it has been successfully controlled with whatever your initial therapy is, and please understand that it has to prolong survival with good quality of life. Professor Sahoo is yet to show a study where survival is prolonged. I will show you your TNBC study very soon and tell you why that is not a great study to quote. Right? So this is the maintenance drug symmetry. Sahoo, I hope you have visited this. It is not in Bhopal. You have to come to Hyderabad. Right? And whenever I hear about stem cells, angiogenesis, immunotherapy and all that, I remember interferon. Okay? That is the one that is deepest in this grave, and that is the one that started with the same story that we are talking about, metronomic chemotherapy. You know, immune modulation, cancer stem cells, anti-angiogenesis. Where did all of them grow? You have to dig Sahoo. So when you come to Hyderabad, maybe I will dig it for you and show it to you. So that's the maintenance drug symmetry. All rest in peace, and you will remain underwater. So is maintenance therapy the standard? Okay, Sahoo said it's standard in breast, colon and lung. I have to remind you that the hazard ratios for maintenance chemotherapy in all of these range from anywhere between 0.87 to 0.92. Terrible hazard ratios, right? So you don't want to give treatment endlessly and then tell your patient your risk of getting, or your risk of dying because of disease goes down by 10%, 12%, and so you want 30%, 40% relative risk reduction. You're not talking about single digits. This is not absolute improvement. Sahoo, Cairo 3, the first progression-free survival was significant. Second progression-free survival was statistically significant, but the difference was 1 month. The overall survival was not significant. Okay, so that ends there. Breast, the hazard ratio is 0.92, 8% relative risk reduction for overall survival. No good. Cost, terrible. Quality of life, poor. So no role at all there. So what is the pretext based on which you're going to do metronomic? That's what we've been hearing time and again and again and again today. Favorable toxicity for long-term use, low cost, $1 a day. David Kerr seems to have got into everybody's brains. Efficacy to target angiogenesis, immunomodulate cancer cells, same old interferon story. But what is the problem with metronomic maintenance? You know, we all are moving towards personalized therapy, and then we are going 3 steps behind and saying, use the same set of drugs, put it into a box, put your hand inside, pick one, and then start. Right? Professor was saying that it is going to fail in a vast majority of patients. So when it's going to fail in a vast majority of patients, you can't have 4 drugs and say, you know, these have anti-angiogenic, immunomodulatory, anti-stem cell effects, and I want to use the same drug. You know, somebody wants to do capecitabine and endoxan together. You know, it's like -P, brufen and paracetamol together. Right? They think it's as simple as that. There are no good standard established surrogate markers for activity, no properly well-designed pre- and clinical studies to determine number of agents, dose, routes, timing, frequency. Nothing has been properly studied. Everybody is making a very nice attempt to do that, but I have to tell you that we don't have anything that's worth quoting in the literature at all as of today. It's been disorganized so far, everybody doing it the way they want to do it. All our panel discussions since morning clearly reiterated the point that people use metronomic the way they want to use it, not the way we should actually be using it, because we don't know how to use it. Okay, and that's what everybody here accepts today, and Sahoo was late because he was sleeping and he didn't know what happened the whole day. What about long-term toxicity? Somebody wants to give endoxan for 2 years. Have we known about what the myelodysplasia or secondary leukemia is going to be there 15 years after you cure somebody with triple-negative breast cancer patient is? We don't know. We are claiming and assuming that toxicities, especially long-term, is going to be better. This is something that my academically challenged brain really picked up to say that if you do not know the right doses, you may be actually compromising, because this clearly shows that if you do not know the right doses, you use the wrong doses, you might actually be causing more trouble than benefit. This is VEGF activity, this is immunomodulatory activity, NK cell activity. So do we know the dose? Excellent. Banavali sir and group are doing a trial to determine dose and look at all these issues here. So we don't know the dose. If you do not know the right frequency, again you might create more problem than benefit. So we do not know the dose, we do not know the drug, we do not know the frequency. Sahoo, what do you actually know? You smile really beautifully. Okay? Keep smiling. So if you want hard scientific data, this is 2016 published all maintenance trials in breast cancer. You see very clearly that all the PFS is 0.00001, but all the overall survival is point, plus the number comes immediately, which tells you that there isn't any overall survival benefit. And this is what the authors conclude. Maintenance chemotherapy has some benefit in TTP in some cases, very rarely overall survival, whereas worsening of quality of life, not your life, Sahoo, patient's life, was the most frequent outcome. There are plenty of limitations, no quality control, data is poor, the induction is varied, we don't know the hormonal HER2 status, quality of life most often was not evaluated. So let's not assume that because you're using a small drug in a small dose for a short period of time, your quality of life is likely to be good. There are some good studies that are being done. Till they come, let's not assume that quality of life and efficacy will be better. This is head and neck cancer. Like in many studies that you see, the ending is, happily everybody lived ever after type. Surely, further studies are needed before metronomic chemotherapy can be successfully integrated. So nobody is really saying it's standard. Your own study here, your Egyptian study, it probably is not balanced because FECD was the control. The study patients had carboplatin in triple negative breast cancer where the median age was 46. So did they know the BRCA status? We don't know. So why did they give carboplatin? Because the trial was already fixed, like this match has already been fixed. The PI wanted really to have a positive study, and so he made sure that he adds additional drugs onto the metronomic arm by giving carboplatin early in triple negative breast cancer and then saying, look, we have produced overall survival benefit. So the arms are not balanced, Sahoo. So you can't quote this saying that metronomic maintenance is what did all this. Is it truly cost-effective paclitaxel in ovarian cancer? Yes, people accepted that weekly paclitaxel is a problem. So no large randomized studies, moving away from personalized medicine. I think it's more socialism than science. It's more populism than science that it's metronomic. It's not really great science. So what most people think is that it is the modern oncologic practice of homeopathic medicine, appealing for being minimally toxic, cheap, and being minimally or non-effective. So that's what is the modern definition of metronomic chemotherapy. So don't assume anything, Sahoo. The left is before marriage and the right is after marriage. The one on top is me and the one on the bottom is you. Right? You do not have hair, so you can never look like the one on the right, Kim Jong-un. This is not you and your girlfriend, so you can be saved about that. I met your wife. I don't want to tell her about this story that we did in college. Right? Incidentally, Sahoo is 1 year junior to me, so I know everything that he did at college. So, my dear friends, all these people here, the one in the middle is David Sackett, the father of evidence-based medicine. Tony Mock at the bottom, charisma-based medicine. The one on the top is William Osler, okay? Eminence-based medicine, because obviously clinical trials were not there. But what our friend is doing is that he wants to push his ideas onto all of you and say that this is standard, so this is eminence-based medicine. If you do not think so, where do you want to fix maintenance chemotherapy? Eminence, vehemence, eloquence, providence, diffidence, nervousness, confidence. Okay? Try to push metronomic maintenance into one of these and then decide when you finally come out of water as to whether it is standard or not. So ladies and gentlemen, there's absolutely no role for metronomic maintenance in solid tumors today. Thank you so much.